Hello everyone, this is Dexter B, and this is a short presentation on APRV covering some of the basic mechanics as well as initial settings and early management of APRV. So fundamentally, APRV is really just spontaneous breathing at kind of like alternating levels of PEEP. There's a very short periodic release of the pressure between the high pressure down to the low pressure. This allows for the bulk of your CO2 removal and assists with the alveolar ventilation, which may need some help depending on how strong and regular your spontaneous breathing aspect of APRV is. Some of the base benefits of APRV include being more flexible with the spontaneous breathing phase. So not having an I time for the spontaneous breaths allows the patient to structure their own breathing a little bit better and to try to be a little bit more comfortable. It's already probably an uncomfortable circumstance that they're under. Lower airway pressures can be used to create a tidal volume, as well as limiting your overdistension. This just comes from the fact that at its core, this is still a pressure mode. It's pressure controlled. So you're not going to see any wild pressure changes that you don't have built into the settings. A little less dead space management, and the high CPAP level maintains mean airway pressure while still allowing spontaneous breathing. This is just, again, a real important part of APRV. Traditional pressure control doesn't allow for spontaneous breathing during the inspiratory phase, and this is where you run into a lot of your dyssynchrony with patients. So APRV are CPAP with releases. So again, we're allowing for spontaneous breathing, optimizing our recruitment, and really should only be used on patients greater than 8 kilos. So when we look at initial vent settings for APRV, the first one is very simple, FiO2. It's recommended between 50 to 100%. Very simple, just set it to 100%, save yourself a little bit of headache. Our pressures are split into our two groups, basically our P high, P low, T high, T low. P high, if you're able to get a plateau pressure on a conventional mode, just set your P high to that. If they're a little dysynchronous or your vent is just not registering a plateau pressure, another option is just to go 5 above your MAP. Both are pretty acceptable. P low is always going to be 0. On APRV, we're going to intentionally auto-PEEP them, so you do not need to set a P low. Your T high is going to be around 3 to 5 seconds. You're going to get some physician variety in here. When I started, I usually start right in the middle, just start at 4, and a lot of times you're going to end up pretty close to that. And same thing for your T-low, pretty close. It's going to be about 0.2 to 0.5 seconds. Again, starting around 0.4 is really easy. So if you remember 4 up, 4 down, 4 high, 0.4 low, really good starting numbers. You'll be very, very close to the optimal settings that you're going to look for. You're going to end up adjusting your T-low by evaluating the expiratory flow curve. The goal of this is to maintain the terminal peak expiratory flow rate at around 50 to 75%. We'll discuss this in a future slide, how to set that up. It's actually very simple. And then the last thing is you're going to set the automatic tube compensation at 100%. What this does is adds a little extra flow to the system, and since there is no pressure support for their spontaneous breathing, this is going to help with some of the resistance of the ET tube to make your patient's spontaneous breaths just a little bit more bearable. All right, so how to set your T-low. This is kind of referred to as like clipping the waveform. So to set T-low, freeze the waveform when in view 5. So you're going to get this kind of view set up here. With the waveforms frozen, you're going to dial the knob to find the peak expiratory flow rate. So if we look on our middle graph where that red line is, it's kind of lined up on that expiratory flow, and it's right. You're basically going to look like for the highest negative number, the most negative number you can find. And that number is displayed in red on the top right of the graph that you're looking at. Then you're going to dial the knob to find the terminal peak expiratory flow rate at the given T-low. So this is your clip. This is, if you look at this graph here, you kind of see how there's this nice almost 45-degree angle sloping back towards baseline, and then just kind of a sharp clip up. And basically you're looking for that little corner. You're going to measure that number. You're going to get a percentage between those two numbers, and then you're going to adjust your Tlow so the peak expiratory flow rate is between 50 and 75%. So use that percentage. That's your goal number. So our goal is to set that clip of the peak flow rate to 50 to 75%. If you get a percentage and it's less than 50%, that's too much time to exhale. We need to decrease our Tlow to allow a little bit more air trapping. We don't want them to go all the way down to baseline. We want to have a little bit of auto peep just to prevent the alveoli from collapsing. If it's more than 75%, you're going to have kind of the opposite problem where they're not exhaling enough, and you need to allow for a little bit more time to exhale. So you're going to adjust your Tlow to make it just a little bit longer. It's important to make these adjustments very slow, usually about 0.1 at a time. Let them have a few breaths, remeasure, and just go at it very slowly, very carefully. So taking a closer look at a Tlow that is too long, we kind of see in our pressure waveform that it's almost to baseline. It's a little hard to see right there, but we're getting really close to baseline. So we're going to need to decrease the amount of time that this breath remains at Tlow. If we look on our flow graph, you can actually see that clip. You probably don't even need to measure this one. You can tell right off the bat that it's too long. We'll need to make some adjustments. So you'll still do the same process of measuring those two flow points, getting a percentage, figure out where you are, and kind of making your adjustments. So we can see that half a second is definitely too long for this. So I would make an adjustment of going to about 0.4 on this, give them a few breaths, remeasure, see where we are from there. And then same thing on the flip end. If without having an issue with it's more than 75%, I'm going to need to make the Tlow a little bit longer due to not having enough time for our CO2 clearance. So take a look at this graph. It's a little bit more difficult to see, but you can kind of see, at least on the pressure graph, it's a very small little dip. We're not really allowing for a long time to allow some of that CO2 to be released. We look at our settings here, it's set to 0.25 for our Tlow. So for this patient, we'll go up to about maybe 0.35, remeasure, see where we're at. So after making some adjustments, here we are back at looking at the graph again. So we see that with a remeasure, we have a peak expiratory flow of -40. We measure the clip, we're at -32. That gives us about 75%. So that's a good spot to be at. We would leave it there for this patient. So adjusting settings to correct your blood gases on APRV. If you are having an oxygenation problem, first thing is pretty straightforward. If your FiO2 is less than 60%, get it up to 60% at least. Also consider if you need to go up to closer to 100, you can do that as well. Consider getting a chest x-ray to evaluate lung expansion. It's very important that, especially with initiation within the first 2 hours, or right around the 2-hour mark, getting a x-ray to see how well you are expanding the lungs. The P high that you set may not be enough pressure to open up the lungs as much as you need. If your FiO2 is already greater than 60%, or you're already maxed out 100%, you can increase the P high about 1 to 2 centimeters at a time, up until about a P high of about 40. Once you get to about a P high of 40, then you're going to start working on your T high a bit. You're going to start expanding that. So you're going to go by about maybe half, 1 second at a time. Keep in mind that as long as you go up on the T high and you're adding more T high, that's going to reduce the amount of those pressure releases in a minute. So this will affect your alveolar ventilation a little bit. And also consider recalculating your expiratory flow rate and your clips. Make sure you are in that targeted range of 50 to 75%. It is very easy to get out of that range. And on the flip side, to improve your CO2 removal, first and foremost, suctioning, very easy, most common issue. They just got some secretions in the airway. Um, Consider recalculating your expiratory flow rates. Again, this will drift off all of the time. It's really important to verify that you are still in your target zone of 50 to 75%. Consider getting a chest X-ray. You never know; something could have happened. Pneumothorax can happen. You can have some more volume loss. You may need to adjust your pressures. It's just good to take a look and see what's going on. When you're going to start adjusting settings to improve your ventilation, so you're going to increase your P high by about 1 to 2 centimeters up until about 40 centimeters of water, or T high by about 0.5 to 1 second. So to improve your minute ventilation with alveolar recruitment is when your alveolar recruitment is adequate. So with the T high, we're going to go down this time. So we're going to, by going down on the T high, this 0.5 to 1 second at a time, we're just adding more releases, more of those big dumps of air to get more CO2 out. So just some final thoughts for APRV and kind of wrap this up a little bit. First and foremost, so this is not a rescue mode at all. If you have a patient with a 6-8 incalculable blood gas, APRV is going to be extremely difficult to use on those types of patients. This takes a while to work, hours, maybe even days, to allow like that pressure to open and re-expand lungs. If you're having immediate ventilation crises, this is not a great mode to use for that. It's important to check this often. Our guidelines right now is just recommended Q3. However, just be mindful of these kinds of patients. Stick your head in. You don't need a full check every single time, but know what your waveform should and should not look like, and just checking in with your nurse, making sure that they're comfortable with the patient and being on this mode and answering the questions that they might have. And while you're talking with the nurse, it's also important to be very mindful of your sedation levels as well as like the use of paralytics. A very important part of APRV is the spontaneous breathing aspect. We do want patients to spontaneous breathe for a number of reasons. And we want to make sure we're not getting too overzealous with sedation or just kind of willy-nilly giving paralytics. Make sure to work with your team, your nurse, your physicians, kind of addressing any of these issues that might come up.